Hi class, today we are going to discuss diabetic ketoacidosis management step by step. Number 1, initial assessment. Assess airway, breathing and circulation. Check vital signs, mental status and level of dehydration. Establish 2 large bore IV lines, attach continuous cardiac and pulse oximeter monitoring. Send blood for urgent investigation. Number 2, initial investigations. Capillary blood glucose, venous or arterial blood gases. Serum ketones or urine ketones if unavailable, urea, creatinine, electrolytes, especially potassium, CBC, serum osmolality if indicated, ECG, urinalysis and culture if infection suspected, blood culture and chest x-ray if clinically indicated. Fluid resuscitation, start 0.9% normal saline immediately, 1 to 1.5 liter during the first hour. Adjust in elderly patients or those with heart or kidney failure. Continue IV fluid according to hydration status, sodium level, urine output and hemodynamic responses. Number 4, potassium replacement before insulin. Always check serum potassium before starting insulin. Potassium less than 3.3 millimole per liter, hold insulin. Give IV potassium until potassium is greater than 3.3 millimole per liter. Potassium 3.3 to 5.2 millimole per liter. Add 20 to 30 millimole potassium to each liter of IV fluid. Potassium greater than 5.2 millimole per liter. Do not give potassium initially. Monitor frequently. Insulin therapy. Start regular insulin IV infusion at 0.1 units per kg per hour after potassium is greater than 3.3 millimole per liter. A bolus is generally not required if a continuous infusion is started promptly. Aim for a glucose reduction of 50 to 75 mg per deciliter. Means 2.8 to 4.2 millimole per hour. Add dextrose when blood glucose falls to less than 200 mg per deciliter, 11.1 millimole per liter. Add 5% dextrose to IV fluid. Continue insulin infusion until ketoacidosis has resolved. Number 7, monitoring. Early blood glucose, electrolytes, venous pH, bicarbonate and anion gap every 2 to 4 hours. Strict input and output charting and urine output. Continuous monitoring of vital signs and neurological status. Number 8, identify and treat the underlying cause. Common triggers include infection, missed insulin doses, myocardial infarction, stroke, pancreatitis, surgery or trauma, certain medications like corticosteroid and SGLT2 inhibitors. Number 9, bicarbonate therapy. Not routinely recommended. Consider only if arterial or venous pH less than 6.9 following institutional protocols. Number 10, phosphate replacement. Not routinely required. Consider only in patients with severe hypophosphatemia, respiratory muscle weakness or cardiac dysfunctions. Number 11, resolution of DKA. DKA is considered resolved when blood glucose less than 200 mg per deciliter and at least 2 of the following: serum bicarbonate greater than 15 millimole per liter or venous pH greater than 7.3, anion gap less than 12 millimole per liter. Number 12, transition to subcutaneous insulin. Ensure the patient is able to eat. Administer the first dose of subcutaneous insulin. Continue the IV insulin infusion for 1 to 2 hours after the first subcutaneous dose to prevent rebound hyperglycemia. Important points: do not stop insulin solely because blood glucose normalizes. Continue until ketoacidosis resolves. Correct dehydration and electrolyte abnormalities carefully. Avoid rapid correction of serum osmolality to reduce the risk of cerebral edema, especially in children. Monitor potassium closely throughout treatment as insulin therapy lowers serum potassium. This approach is consistent with current recommendations for major diabetes organization for adult DKA management.